Okay, so welcome. We make it such rather informal, and we encourage a lot of discussion here. And if we have discussion on Facebook, we can type the comment there as well. How I do it session, and this session is recorded, and we will put it up in YouTube later, and also Microsoft Team Active Learning site. So you can come and view it another time. So today we start off a session, two sessions, half an hour each, and Dato Ainul will share on clinical teaching in COVID era, which is a bit challenging between fantasy and reality. So we need to work on a reality. Okay, we can fantasize a lot of things. Well, I will be sharing a little of my experience also during COVID time, how to teach team care, which is a little challenging as well. Team is usually come with a lot of practical sessions. So how to do it online. Anyway, well, get some ball rolling. And Dato Ainul, the floor is yours. Dato Ainul is our surgeon, a neurosurgeon from surgical department. And he's very much into education. Yeah, we'll hear from Dato Ainul. Yes.
Okay, thank you so much, Prof. Tong. When I first got this invitation from Prof. Tong, I just said, why not? And then I looked back at all the other How I Do It session. I said, oh my God, I don't know what I got myself into. So I am not, full disclaimer, I'm not a technical expert in any of this e-learning process. So far throughout the MCO period, I'm more towards organizing our teaching sessions and our assessments and all that alongside with the JPP, with the medical education department. So I'm more of the behind the curtains person rather than the technical experts and all that. But I'll try and share some, not really how I do it sessions, some of the experiences and what could, some suggestions. I really like to put it up in the air and see what the other people would want to give their feedback on their clinical teaching during COVID. I heard very nice, Prof. Noraza had a very nice How I Do It session with her magic pens, magic pencils and clinical teaching, which was very good. I tried with my tab as well when I did my teaching session with my CSL students, but they all went to pear-shaped when the videos went off and the internet were a bit offline and things like that. So I just share my screen for a bit. It's not a lecture as such, it's just for me for references and all that, and then see how far we go back and what could be done. It's not going to be half an hour. Hopefully the discussion will be more interesting than my slides. Okay, so I'll just quickly share my slides here. Okay, I mean, the reason why I put up saying that the possibilities between fantasy and reality more or less is that there's so many things that we want to do online. I mean, the potential is there. I mean, Prof. Azmi is here. He knows more than anyone else the advantages of online teaching, the live cams. He's got 5 cameras focused on him, and so hence the picnic that he's having right now. But obviously it's not practical for most of us. I mean, not for, especially not me. Somehow my PC in my office, the MS Teams, is always hanging. I can't get it to connect with me. I can't get the videos. I end up using my tab. So the practical part of it is very limited from it and all that. But most of these online teachings, from what I gather from my department members, is sharing of really theory knowledges, clinical scenarios, rather than the actual bedside teaching and whatnot. So that's the main challenge in this COVID era, is to get the hands-on physical examination part going. So I'll just quickly whiz through. I mean, the challenges started obviously last year when our Tan Sri and Muhammad Tan Sri started locking down our country, PKP, and then from our students in their wisdom started all going back home. So our campuses were empty, and then we were left wondering about where is everyone. They've all gone home and we have to do something. Otherwise, we run the risk of them losing their time. They lost time in terms of their clinical encounters, especially our clinical students, the third year and the final year, the third, fourth, and fifth year. Even my CSL students all lost out. They couldn't get their clinical encounters. They couldn't see their facilitators and whatnot. Then all of a sudden, overnight, our lecturers were expected to be instant online tech gurus and experts. It's easy for Prof as me, but for some of us, we're still learning after a year and a half. But then, lo and behold, we discovered gems in our faculty, Prof Mawada, Prof Farah, and all that. They've actually elevated themselves to higher, greater heights, and they're now fellows in teaching, online teachings or whatnot. And that's the beauty of this. We discovered new talents in online teachings and things like that. But the challenges are still there, especially from the clinicians. The grumbles are always there. It's not authentic. They've lost their clinical skills. We can't get a right, proper assessment going on, especially with clinical assessments. And also I noticed changes in attitudes as well. Even now when the students started to come back to the campus, we tend to give some liberties to our lecturers and students to say, your time in the ward is limited. So how do you want to go about your teaching? Do you want to meet up and do something, or do you want to go online? And more often than not, some of the comments from my members of the department would say, online lah, senang no online. The reason for senang no online is all they have to do when they say online is just switch off the camera and then they just doze off. That goes for my kids and all that as well. So, and they think they get off scot-free, saying, oh no, my lecture's not going to look at me now, I'm going to get away with it. I do notice some attitude change with that when this happens with online teaching. So these are the main challenges. Other than, there's a lot of things as well. I mean, you don't get your hands on and things, but the attitude change seems to be there as well, especially when we go on, say, oh, this online. So what happened last year? All these things starts to shuffle around. This is when the MCO, when the kids were not here, and I think Dr. Nasri will be very familiar with this. The whole assessment committee was like scratching their head. How are we going to do this? The kids are not around. We still have to shuffle and then we end up pushing the exam towards the end of the year last year. I don't think that's going to happen this year. The students are all back. So, but these are the horrible things that we had to make do last year. And the adjustments we had to make. Obviously, this is very blurry. I apologize early on, but this is the Miller's pyramid for assessing clinical competence. So with the online, if we're looking at online teaching and assessment, we're really just looking up towards the third part here, the shows how. That's the most you can get really with the online and this with the students. The does part is very difficult, especially if they're at home. There are some differences when they're back in the campus. We do have some flexibility and some latitude there, some laxity in it. But when they're at home and they're not allowed to come back to the campus, it's very limited, especially when we're looking at the Miller's pyramid here for assessment. So this is what the suggestion by our JPP department last year. What can we do in terms of teaching and learning when they come back for post-MCO? And we've had a whole assortment of possibilities there, online synchronous, online asynchronous, where we actually have the DXR clinician on board. Dr. Teroaila was very gracious with her presentation in how I do it session. It's still confusing. I'm on the DXR clinician committee and I still have a lot to learn from it, but the value from it is very good. And then with the face-to-face outpatient, it looks like after the MCO last year, when students start to come back, we feel that, all right, things are starting to come back to normal again. So we don't have to worry about this online brouhaha and all that. But then, so what we did was a mixture of online using our famous UKM folio. We're all experts now, uploading our teaching materials. We've done our Zoom streaming like we are now. We have recorded video sessions and discussions, and we have our DXR simulation. And then we've got our beloved face-to-face teaching coming back. So which was, I thought, all right, this is great. We're coming back to normalcy now. And we've got some we're going back to normal, but we're not going to abandon our online teaching and learning activities now, since everything's come, we've started it and there's no point abandoning it. But, and this is an example of our UKM folio. You can see how backwards mine is. It's all very simple and just sharing slides and all that. I see Prof Mawada with all her quizzes and all that with her UKM folio, which is great. But then, and this is my own personal experience, where I mainly use Zoom meetings, Zoom experience. I'm not going to share some of my students' Zoom video recordings. Some of them were quite embarrassing, not with the students, but some members of their family, which they weren't aware, walking around back behind their backs and all that. So that was quite an experience. And we have some video recording for assessment. And I'll just share you one video recording. Well, the reason I wanted to share this is what what we have in terms of the experience and authenticity and how we're going to teach them. Just give me a second. I'll just share. Where is my? Okay. Just bear with me. Is everyone okay? Yeah. Just bear with me for a sec. All right. The sound is not very good, unfortunately, but I'll just share you some of the recordings some of my final year students had. And this is when they're at home and they're with their siblings, obviously, and they're trying to teach. And it's a recording. So they're doing it on recording. They're having, demonstrating. This is Atika, I think they're all doctors now. I think they're all final years that did their exam last year. So, they're demonstrating everything and you're watching a recording from it. They sent it to you. You're having a recording and you actually basically do your own assessment, and then you connect with them again, either through WhatsApp or through Zoom, and give comments and feedback from it. So there is some element of feedback and assessment from it. But the problem is that for clinical teaching, physical examination, you actually want to give it real-time feedback to them. You actually want to say, oh, hang on, let's stop back, let's go back to what we're doing here and whatnot. And I know it's impossible to do it with the Zoom and the internet connectivity problems and all that. It's very difficult, especially when they're at home, and we're sometimes at home as well. All right, so I'll just stop sharing now this session just to show you an example. And actually, to be honest, sometimes when you do this, watching the recording without the interaction with the students, what happened is that you start dozing off as well, because you have 12 students, 6 to 12 students looking at it, and you're going on and on looking at it and giving. It gets very dry, and the students, when they're doing it, they didn't have their feedback back then. So that was one of our attempts to do physical examination, clinical assessments online, and it wasn't easy. We lose out on the authenticity. It was awkward using family members as well. They didn't understand what was going on, and they didn't have any signs, and the feedback was a bit later. And sometimes the teaching moment was gone. For me, when I do clinical teachings and bedside teaching, there's always certain teaching moments that you want to stop and let's have a chat about these things and how we can further elaborate on those things with physical examination. With online teaching, in terms of history taking and tutorials and case scenario discussions, it's pretty much straightforward. I mean, everyone has done it. We've done our tutorials even when it's not online. So when you do it online, the challenge isn't there, but the physical examination part is very true. But then lo and behold, when they're back, we thought everything's going to be back to normal. We have all these incidences. My students in Teluk Intan came back, had their swab, it's positive, and then it goes snowball, their classmates in the car and this, and then it ended up everyone going to quarantine for 10 days. They go back to their rooms and they become non-contact, and they lose this opportunity. They don't get their face-to-face teaching again. So it's like, oh my God, 10 more days without any encounter and all that.
Sorry,
and then
I can't send messages yet.
Sorry, that was my other device saying I can't send messages yet. And then we have sudden ward closures as well. We've got announcements from our pengarah saying these wards are closed and all that. So what can we do? I mean, how are we gonna? They only have for our current final year, we have 6 weeks with them. 7 weeks. 1 week mainly lectures and seminars and whatnot. In 6 weeks, 3 weeks in campus, 3 weeks in Teluk Intan. And God, how are we going to maximize this time with us? And I'm still at loss. I don't know what's the best way to do it. And our current practice in the surgical department is we've actually made it uh, we've got more than 40 lecturers in our department. So we get about 30 odd students coming out. So we've actually made it one-to-one supervision now. So it's one supervisor to one student for certain assessments. And we made it into a very small group of students so we can dedicate our time. It's not to say that the teaching is one-to-one, but we make it into small three people in a group and three lecturers, and they can swap around the lecturers to teach and all that. But when it comes to assessment, it's one-to-one. Especially the long case assessment and all that will be one-to-one. And we do a rotation system for our students that they'll be in the ward for 1 hour period, so minimize contact and risk of COVID exposure. And in the clinics, we follow the SOPs, one student to a clinic. Endoscopy and OT is very touchy. It's very touch and go because the endoscopy is very high risk. But some of our lecturers do actually conduct very good teaching sessions in there. But we have to maintain a very strict SOP, and at the moment it's very difficult because there are our trainees, our postgrad trainees are there, our nursing staff and all that. It's difficult to maintain the SOP. So, but we will do it according to what the SOP and the lecturers are allowed to. In the OT as well, we allow 2 students in the OT, but it depends on the SOP. And I do lately now, I've actually given the freedom for the students to come to the wards after office hours and start doing getting their clerking and physical examination with the patients and all that. And I don't do designated on calls with them. I give them a bit of freedom because they have to negotiate with the other groups as well to go in to see the ward, because we have allowing only 5 students to the ward for exposure. But then the teaching and learning methods are individualized to the lecturers, okay, with due consideration the learning outcome and the syllabus, but it's up to them how they're going to go about their bedside teaching and how they're going to do about their online teaching and all that. So that's our current practice now. And I don't know whether it's effective or not. We'll know soon enough in our professional exam. I mean, I can't really do much radical changes in our teaching learning activities now, especially when the situation is very fluid and all that. But there are a few things that I've come about in the literature and reading through certain advances done in publications and all that. So I thought we'll just share some things. And why I say it's fantasy and reality, some of them are in our fantasies because of obviously budgets and technical limitations that we have. But I'll share some of them as well. The fantasy ones are obviously the virtual reality and augmented realities, high fidelity simulations and all that. It's great if we have them. I've been to MMU and looked at their virtual reality setups, and I mean, they've come leaps and bounds in it, and they have students that's working quite hard with it and all that. And I've looked through the internet and seen what they've gone through with the virtual reality ward rounds and augmented reality, and it's really good. It's there for the taking. It's whether our own will and our dedication for us to go and pursue that as well. And high fidelity simulation. I had the honor of playing with one of our sim men in our department more than 10 years ago with Mr. Hyro last time, where we had one of these high tech simulation sim men in our department that we started playing around with, and it was quite something. It was a nice experience to have. It's not that you're the facilitators there say, oh, the blood pressure is dropping. It's actually there to be seen, the beep with the monitors, the blood pressure is dropping. You can even hear the sim man saying, it hurts and things like that. So that's high fidelity simulation. Obviously cost is a problem there. and it's a major obstacle for us. Virtual ward rounds, I just shared. This is the VR simulation here that you have. You know, it'd be nice for us to have a smaller goggles and all that. But you have this simulated ward clinical encounter with the patients and all that. It lacks the tactile authenticity, but at least it has some clinical environment for you to have. And then these are mainly for our probably postgraduate trainees as well with the VR. I've got loads more of images, especially with our microscope and endoscopy work using virtual reality. It helps us for our training. And this is the example of our sim man. It's as real as you can get. I think the ASSC has that kind of environment, but I don't think they have the sim man available there. So we can run scenarios after scenarios of emergencies I mean the ACLS has done it. The emergency department people have run that quite nice, effectively. But we got more scenarios with the sim man in terms of for surgical part, PR bleed, upper GI bleed, and things like that. We can run through the simulation here. Virtual ward round, which is introduced in the UK, and they're running it now. Apparently, they're using Google glasses or and whatnots, and they're using body cams for their physicians to go in their ward rounds, and the students have access to the virtual ward rounds. And I honestly see why we can't use it here. We have tons of people using GoPro with their bicycles and bikes and cars and all that, and I can't see why we can't use that simple technology for us to go on our virtual rounds and all that. Obviously, there is a major problem with data protection, confidentiality, and all that when you're doing virtual ward rounds. But this is something that we do need to look into, especially if there are instances where the students are not able to come around in the ward rounds. As it is now, I feel sorry for my students. They can't come to the wards because they're not allotted that time. So they can't join the team's ward round. They can't find out what the management and all that. They just have to start reverse engineering it when they do come to the ward, having a look, have a chat with the registrars and the housemen in terms of management. It is important for our final year students, especially because it's meant to be a clerkship period now where they're basically junior housemen and want to go to see the roundabouts and the runnings of the wards and how they can be a functional unit within the ward, which is a bit difficult now because of the restrictions. This is telehealth, the advanced telehealth. It's not just sitting down in front of the computer. I saw one news reel, a documentary where the Israeli medics, basically all the potential COVID patients stay in their apartments, and they were delivered a box there, and the box has all these nice neat camcorders, view cams and all that, and certain equipments to measure your SpO2s, your temperature and all that, and the view cam is high definition, and they can basically look in the throat and all that. So they're basically doing teleconsults from a distance for all potential COVID patients, which I thought was quite good. But these are the ones that I'm saying, these are the fantasy parts that we're hoping that we could get, but obviously we're not quite there yet. Okay. And what are the possibilities? These are the possibilities that I would like to see whether we can try and maximize these things. One is peer teaching, peer tutors or peer teaching amongst our medical students. It's not to say that, okay, you guys choose amongst each other and all that. This one, you probably have to have some enforcement to it, that we start to say, okay, for this session or for this week or anything like that, I'm allotting you as the peer teacher there. Okay, the reason for this is that we can't be there all the time. We can't be monitoring what they're doing all the time. Okay, so we need to entrust some of the students here to take up the responsibility to be the person who actually leads, in a way, lead and start to comment on their peers in terms of physical examination. They have these peer teachers, peer students will have access to the teachers, to the supervisors, the lecturers and all that. Sometimes it's, as we go down, you see that I wish that all patient encounters from now on with the students, with the patient's consent, obviously, will be recorded. So it's something that they could keep for themselves, and then also bring it up as a discussion period with, as a discussion point with the lecturers. The reason for this is we don't know when the next time these students will be quarantined, or next time the ward will be closed and all that. We just have to make use of the best, make use of the best time that we could when the students are in the clinic, are in the clinical environment, in the wards or in the clinics and all that. Obviously, it's not easy to record everything, but this is a possibility that the students will have to take initiative as well. The next one I was thinking about is reducing the passive clinical encounter. The reason for that, I don't want them hanging around not doing anything. Okay, it's sometimes when you do have team-based with our surgical students, they are allotted the upper GI teams and colorectals and all that. So they are responsible for the patients that they're looking after. But sometimes the patients are not there. It's not all the time, but they don't have patients to go and see. And they're not sure what to do and all that. So this is where some of the supervisor or the teachers play a role. They have to do a bit of extra effort in terms of assuring that knowing when their students are going to see the patient, to be in the ward, and assigning specific patients what to do. It sounds a bit like spoon-fed, but at this time, it's important that we reduce the non-essential contacts with the patients and being in the ward, and just make them focus and get it over and done with and come out. It make them a bit more focused, and it reduces their time, their exposure in the ward, and hopefully reduces their exposure towards this COVID drama as well. So it makes it more focused. The next point will be recording patient encounter with their consent. So you gain something from it. You can reflect on it as well. So, it's all nice to say, oh, I'll sit back, go back to my room and reflect on my practices. But when you do have recordings of this, then you have a lot of things that you can look back and comment on yourself as well. Okay. The other thing is when you do have teaching, online teaching, I'm not saying that once we're back to face and all that, there shouldn't be online teaching. I think there should be. I mean, there are certain times where the lecturers can't be with you, and you also have other teaching sessions and all that. So when you have online teaching, you have this flexibility. I mean, don't go about when you do online thinking about physical examination and all that. You start discussing about the management, the theory behind it, pathophysiology to it. And the beauty of doing online teaching is you can actually demonstrate and visualize the anatomy and the pathophysiology. It's not all about us talking, chit-chatting and all that, but you can actually, just start screen share certain parts. You say, okay, I want you to look at this. This is what we're actually doing. We can even share for surgeons, we can share some of our surgeries with them. And, they most of the time when they're coming into OT, all they do is sit at the back and just, quivering away, sometimes within their pants, thinking, oh, what are the surgeons going to ask me? What are they going to ask me now? I don't know. But this one, with this kind of the online and all that, you can just share the actual surgery itself. For us in neurosurgery, our microsurgery, under the microscope, we can record it and we can share it with them. Say, okay, this is the vessels that we're looking for. These are the parts that we're trying to avoid. We can even quiz them. What lobe is this? Or what part of the anatomy that they can have, and they can actually visualize that. And those are the opportunities that we should embrace with online teaching. Since now, after 1 year, we should really be experts on it, minus myself. But we should use this as an opportunity, and less verbal and more audio visual and stimulations with the students. Some of us are experts in doing quizzes and all that as well, like Prof. Noraza did with her sessions as well. And there's nothing wrong with doing that. And that's what I thought the online teaching gives you, that kind of opportunity to have. I thought I share this patent four-stage approach. It's actually with used by in the CPR training in terms of demonstrating. This is where I thought I'll just share this there. We cannot actually be with the students, and the students can't be with the patients as well in the clinical setting. So they might, this is when during the quarantine period, or they have to be in their dorms and all that, and they can't come out. So I thought I'd just show you an approach done by, this was done in Germany, I think, and they did a CPR training, and it's called patent four-stage approach. I think if Prof. Ismail is around, he'll probably be very familiar with this. And this can be used by our lecturers, by ourselves, by the students, peer teacher students, and you can from the level of CSL in the first and second year up to the final year as well. The approach is very simple. It's not to be substituted, but it's a simple thing for us to demonstrate clinical skills and clinical examination. We always take it for granted. With our students, we say, okay, this is how we do it, and come and now next you show me how you do it and all that. This one is very elaborate as to get the student to come to a breakdown of the examination, to understand, and for them to execute with all with us being there and discussing the nitty-gritty parts of it. This one was done in this project was done in the UK, in one of the London medical schools, in their CSL, in their clinical skills for the preclinical students. So they actually demonstrate, verbalize it, discuss the skills of what the teacher's doing and all that. And then the student, at the end, after the student showed their understanding, then demonstrated to the teacher. So this is for face-to-face. But when we do face with online teaching, so they've slightly modified it where we can't show, we can't demonstrate, say we can't even demonstrate with our friends in the wards and all that. You can share the videos, YouTube videos for examination, but you actually break down the videos where you have demonstrations by that video and at normal speed without any commentary. Then you have the breakdown of the assessment. You can even, the teachers can actually break it down. You can pause it and say, okay, what do you think we're doing here and all that. And that's the great thing about online teaching with this, is that you can break it down and pause and discuss bit by bit with it. And then you check the comprehension by asking the student to narrate what the demonstration of skills is doing. It's the same as the face-to-face one, but this is for the YouTube videos and all that. So rather, and the modified part is the consolidation. Rather than the student executing it, then you have Q&A and clinical contextualization of what you're doing with the physical examination. That's for the PE part. So I thought this one is something great, good to share with our clinicians who are at times difficult to demonstrate and discuss physical examination with the student. It's not a substitute. By far, it's not a substitute, but it's an adjunct for us when we do have very limited time to have with the students as it is. And this is something I thought would be interesting to share with our teachers. Online materials, there are loads and loads of online materials. Geeky Medics I got from Prof. Noraza, where you have a lot of scenarios and clinical case scenarios, YouTubes. What I said before with surgical and endoscopy recordings, actually is a great opportunity. The students can actually see what you're scoping and all that for the gastroenterologists and for our surgeons here. And you can actually go in more details of what you're doing when you share your recording with online, and your own recording for consultations. I've got recordings of our family medicine in Clinic Prima for our CSL students, but I won't share it here, the confidentiality and all that. But I saw them and it was great. The videos, the quality was great. And even we had an introductory video on the clinic primer and all that. And I thought that was a really good alternative for the students not being able to come to the physical settings there. And we've come a long way in trying to demonstrate things that we tried to replace when those couldn't come on the physical part. Now, what do they do? What do the students do when they're not in the wards? Hanging around, being in the room, watching Netflix and all that. But we can try and encourage them, or obviously we can even try and force them to utilize our sim lab. But I think Dr. Hafizo is around. He probably can vouch for me. I think they're overbooked now with the sim lab, with the students just coming in and out and filling up these places and all that. But these are the ones that we have on our 4th floor, which is, you know, the more than enough opportunities for them to have a go. Now, lastly, for me, the simulated patients and role play. I know for the clinical students, it seems as if they're regressing. If they're going back to this is when they'd have, during the CSL period, simulated patients and role play. But it's an opportunity. It's there for the taking. There's no reason why you shouldn't go back and do role plays amongst yourself. You're learning from each other anyway. You're the patients will be learning the symptoms and signs. The physicians will be learning in terms of how you're going to get the information. Don't tell them that you've got angina and things like that. You know, make it interesting amongst yourselves. And then the lecturers as well can play a role in making these scenarios and role play more relevant in this day and age when you can't be in the wards. They say, can I use the 10th floor? Can I use the 4th floor? Can I use any of the MSKs? Why not? You're there, the students are here. That's the brilliant opportunity when the students are back in the campus. We have all these other options we have rather than just thinking about, oh God, the ward is closed. That's it. We're all, you know, we can't do anything anymore and things like that. So these are the things that I thought would be good to reinvigorate with our clinical students, especially as towards the final year and 3rd and 4th year. So these things, we should be adaptable, we should be robust and aligned with our learning outcomes. We have to be, the teachers especially have to be very well versed with the learning outcome. With our assessment committee, we wondered, can we do a questionnaire whether our lecturers know what the learning outcome for our modules and our things are. And we have to ensure that our students reach the competency level that's adequate for them to become a houseman. So the catch is, this is the main catch. It's very, 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 it's a lot of hard work. The teachers have to put in a lot of effort into this. There's a lot of organization and coordination involved in this, but I think it's worth it. We can't just let our students just wither away and not having, you know, just missing out on their clinical encounters and all that. So that's my 2 cents. I'm sorry I don't have the wizardries and things like that. So, I mean, we try our best and we pray for the best. And I leave it up to everyone else to ask me any questions or for discussions and all that. Just feel free. Thank you very much. Assalamualaikum.
Right, thank you, Dato. I think yes, you have said it all. Actually, it's not all just about the high tech, but I think continuous learning, and you just grab all the opportunities available. I think we have too much time when without MCO, students have abundant of time, abundant opportunity, don't appreciate that, and you just show it, you know, being focused. Anyway, I invite question, a discussion on things, challenges. We're probably going to spend 5 minutes on that.
Yeah, I'm sorry, I didn't realize I went overboard.
Oh, no, it's all right. I mean, it's nice to hear all the real practical experience and how you make use the best or whatever things available. Yeah.
Sadly as well, when I went, because we gave them 1 hour sessions, and when I went to the wards yesterday, it was empty. The students weren't there. I don't know where they were. So it's like, I don't know. So, okay. Any questions or comments?
Yep, exchange experience. I mean, anybody? I'm reading that Facebook, we have 51 follower at the moment. And yeah, I'm reading the text if there is any.
Just to point out that the method that being used by Dato Ainul is also being used by other faculties. For example, FSK, my daughter is training to be a physiotherapist. So guess who will become the
Oops.
Hang.
That's technology.
victim to become the model for demonstration. Unfortunately, the father is too obese to do that. So, but everybody do what they can. They do their best, and hopefully everything goes well.
Yeah. Okay. Yeah. Thank you. In fact, the best thing about recording is that every recording we can pause at any time and comment, and can we go back and relook at it again, which in a real life, if we don't record in the olden days, we could have missed all the details that we want to comment. And yes, it offers a great opportunity. Yep. Right. Yep. Right now what's commenting is so true. Anatomy is clearer in online classes in the Facebook. Yes. So yeah, online is not all bad. I mean, we must now tap on the benefit of both. We think about it. And I think coming along the way, MCU has pushed me to the limits to learn new things, and the great teachers always learn new things. Okay, teachers don't just teach, we learn. Right. So summarize a few points that I think worthwhile for us to take back, message back. What is the attitude change for both our teachers and lecturers, teachers and students? And we got to start trust our students. They have a keen eye to learn if we engage them enough. Yeah, something like that. And yes, it's going to be, whatever we have done is not going to be abandoned. We're going to take all that is good with us in even though we're face-to-face, we're going to engage a lot more hybrid. And no more passive teaching. Okay, that's the motto that we probably want to get. I think focus and get the best use of the shortest time available for us. It makes all of us efficient, right? And those technology around us, we can always intensify. Okay, so that's a chat, I think. Oh, internet speed. All right. Yes. All right. If you can still have questions, you can still type, we can still discuss. What I'm going to do is I'm going to share mine. And again, it is a learning journey. I've been trying a lot of platforms. Asmi has introduced a lot of gadgets and platforms, and also Pengajaran UKM Bangi also introduced a lot of things. And so we've been trying and still get around what's the best work for us. And what I'm going to do is going to share a little bit about teaching teamwork, which is usually on a class project. So I've got a message from dietetic colleague from FSK, and it was a distance away, and it's asking me to give a session on professional teamwork in chronic disease management. Well, this is going to be a task again. So I take it as a challenge, and how can we do that online? So thinking back, one way, the traditional way, we will give lots of information. As a lecturer, we have, in a way, supposed to be already learned to some extent. So these are things we probably want to share with our students, right? So we're going to talk about common goals, share tasks, support each other, aware of each other's role, and team dynamics and whatnot. So this can be given by a lecture. So we can just turn on a Microsoft Teams or Zoom and then give a lecture. But it doesn't satisfy me in the sense that, yes, I've delivered, but have a student received? So this is the biggest question of me. So I kind of think about how can we do that in a virtual platform, right? So as usual, I actually go back and look at alternatives, and these are really face-to-face work. A project or games and reflection, things like that. Again, it's conventional. So how do we do that now? Going back a little bit, so I have to go back to think about what exactly I want to deliver. Thinking about teamwork is really an affective domain, right? Affective domain. It's interesting to note different domains and bring in some theory of teaching and learning to help us to design what we're going to do. So in affective domains, a lot we were talking about receiving something new. How do we respond to that? How we value those things, concepts, right? And later on, characterize those values in ourselves so that in our future work, we will carry this value goals with us. It is really focusing affective, not so cognitive and not so psychomotor. Of course, it will bring us to some skill of teamwork. But the main aim, I probably think we should focus on effective and let students value this deeply so that it sink into their mind, so that in future they will carry this teamwork spirit ahead with them, right? So this is professionalism. So I guess effective is the way to go. So how do you go about doing that? We know the audience is dietetic undergraduate students, and outcome to value effective team. So I have my outcome. What do I want to achieve? So perhaps that's one thing. If I'm going to tell them what teamwork is all about, obviously this outcome will not be achieved. So therefore, students need to know the need for a team. So how do they get to know the need for a team? It's basically trying to be able to know a task that require more than individual effort. If there's a task which is so simple, individual can do it, I don't think there's a need for a team. So they must be able to see a task that require more than one individual. And often this has happened in healthcare. I don't think healthcare, we can be heroic enough to do something, everything on our own. Healthcare become more complex now. So public health, primary care, hospital, all has to be in a team. But this is a task that students need to really appreciate. So how to go about? Underlying the complexity of a task in healthcare, they perhaps need to understand health is complex. If they do not understand what health is complex, then how can they work in a team? They will probably work in silos. So these are the thoughts that I had before designing the thing, designing what I'm going to teach. So by knowing this, then we can go back and redesign what we really want to tell the student. There comes the objective of a session. So we know every class we create, we must have an objective, like learning outcomes. I know talk about it. And it is really true that we need to really spell it out. So then I can design something based on the outcome, learning outcome I expect. I expect them to describe what it takes to be a chronic disease patient, discuss what is therapist's role in patient care. They are therapists, dietetic is a therapist, and discuss on who are needed in delivering holistic care. So I just put on the laser pointer. Okay. Then discuss the responsibility of, and ultimate aim of dietitian in caring patient. At the end of the day, they will need to describe at the end professionalism in interdisciplinary care, right? So it works in a way incrementally built on what they know. If we do something hi-fi and not building on what they know, they will lost the base and then they will collapse from receiving information because things are so far they can't reach. So we have to build that up slowly. So with this learning theory behind me, understanding how people learn, then we're going to go back to the design. This is the analysis part. You can see the A there, it's analysis. And then the design. So going to build the experience. How do we build experience online? In a real case, they come to the ward and talk to patient and get those experience. Now, prior to class, I want them to experience living with chronic disease, how to do that, okay? Then exercise, they can start thinking about what they can do to help the patient. So then that's prior to class. Then during the class, we need, after experiencing, then we can discuss those things. Discuss those things as little short lectures to introduce some concept, but a lot of time is activities, and post-class supplement them with something more difficult or something more conceptual, chronic disease management teamwork, which for a newcomer, perhaps they won't do anything about unless they have read it before. So some new information have to read. If I throw the post-class reading material to them, they won't have a ground to stand. They will probably topple and don't get anything out of it. So, well, Microsoft Team come to help me. So everything communication through Microsoft Team, which in the past, without this platform, I wouldn't have know how to connect with our student prior to the class. I would have walked in the class and everything started new. So probably not so good. So with this platform, we can build really something before the class, during the class, and after the class. So they were told about the objective, okay, of the session. And exactly, we'll do some exercise before the session. So the first thing I wanted them to do was really experience. So how do I get experience? So that I know I talk about many material online. Yes, it is very true. So what I did was ask them to just look for video clips about life experiences. And in fact, there are tons and abundance of things that before even MCO. So a lot of clips are even created before 2000, and people just put up their life story. So they have to look for these clips, right? look for these clips, and then write something about it. This is the instruction for the class. So let them feel and see what other people's stories about, so they can feel and value the importance of managing a patient with chronic complex problems. Okay? So therefore, they really have to post. Okay, they have to post in the notes. I post those exercise and notes, and then some instruction. And these are the clips they found for me, in a sense. So some with chronic kidney disease, some with diabetes, some with inflammatory bowel disease. They write their stories, right, summarizing. And I put up some comment, a response. So our new millennium, they are quick, wanting a quick response. So we must check on them. So in a way, not to check on them right or wrong, but to encourage them, and also reinforce what they feel about what have they watched, okay, what they put up. This is a good way to share, and because by putting it up, their peers teaching each other as well, looking at other stories. They just have to do one, but many of the time they already come to understand many types of chronic disease by looking at their life story. And the life story usually very short, 3 to 5 minutes of things. So well, that's it, the exercise 1. Dato can feel the experience. I'm not too sure at that moment how students will respond, but looking at their narratives, it looks very interesting. Okay, very interesting. Then discuss the therapist's role. So this is the second exercise. Okay, exercise after watching, what do their role is. Get them to think about what they can do to patient as a dietitian. So they'll write their response again in another notes. So their exercise 2 in a note form. So they share their things, what they can do. They did not highlight those though. The highlight was my work. Before the class, I examine what they have done, and then I highlight those common things. By surprise, without even teaching them, they're already knowing a lot of things. So this is what sometimes we go in a didactic session, the lecture, we may not even know what the student knows. So we don't pitch at what their level. So by knowing their level of understanding, we will pitch the right place. Okay, here the blue are a different theme, yellow is the same thing. So they say very common thing. And I don't think they copy and paste, because every narrative is so different. So different. The word use, the sentence use, and all that, so different. So having that, in a class, we do a little summary of what they've learned. So basically, I did not teach them a lot. I summarize what they have taught me and share with the class. So this is a power of co-building, and they take ownership of the answers. In fact, the answers will just consolidate the understanding. So teacher's role doesn't really teach here. So I guess here I've just share what they have shared among themselves. So that's a little exercise prior, and then short lectures on concepts of holistic care. What is overall health? Of course, we can rebuild this another way, but just getting things short, we can ask them. We can actually ask them to look at the internet, literature, talk about what's health, but perhaps might be too much for them to take on, okay, a class. So I've just presented that, a few slides, then come back to the last, discussing activities. So by looking at what health is all about, they understand what patients all about, so what they can do, who are the team players in holistic care. So they have to list this together with me, and we do it together. So once we do it together, it becomes a common piece of work. Okay. So this is the thing they have listed up. So co-built together, again, Microsoft Teams notes allow us to co-share many things on the same platform. So in this particular case with a stroke, they'll probably need a physician, another physician, a family physician who will look at general well-being, a dietitian, speech therapist, and blah, 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 and whatnot. So we co-built together this, and they take home these messages. And finally, to consolidate what they're understanding about team players, then a case study, again, another case study, and they will have to discuss what are the conflicts can happen in a team while we care for a patient. Here, a case study of a patient with multiple professional involvement, and they all have different plans, and how clashes of plans happen, and how do they solve this problem. So by just plain logic, they will come up with beautiful answers and solving a case. So wrap-up session is really something a little bit more heavy, looking at what chronic care model about in the literature to help them to position what they have learned in chronic care model. This is probably the time where we can put on more conceptual, more difficult concept for them to bring themselves higher in that sense. So therefore, must wrap up with a feedback. So they have to go back and get some feedback. Filling my feedback form. Again, Microsoft team, we can use Google Form. This I've used Microsoft, no, not Microsoft, Microsoft 365 come with a form, Microsoft form, yeah. So this is what they do. Ask them to click, created this for them, and they get feedback. So feedback will allow me to know exactly what they feel about the session. So this is their results, and I'm happy that after responses, I learn from them. Their feedback will tell me what I've done correct and wrong, how much I have engaged them, and at the end, whether I will take this continuously or will do that modification in future with the feedback. So I look at the feedback, engagement is really good, and yeah, what I ask them, what do they don't like, almost quite a lot say no, nothing. So I felt so happy because they have actually learned something. How do I know? Because they co-construct EN exercise for me. So when they co-construct, I know how much they know, rather than me telling them exactly what I need to tell them. This is the way they tell me what they have learned. So in a way, yeah. So that's my short sharing of. Actually, I have a last slide. Besides using technology is helping us. Microsoft Teams is a good platform, but you can get any platform. You can Folio, another way to go about, and Zoom, you can go about that too. And but what I did essentially is using an instructional design model that everybody is perhaps quite familiar about. Start a little thinking about analysis. Start a little thinking about how to design it, and develop the module accordingly, and then implement and evaluate. I find this is a very nice, simple model that we can actually embark on, and we get results, and we can co-learn, go back to evaluation, go back to analysis again, and the cycle goes on. So therefore, like Dato Ainul say, we never stop learning, and we learn how to teach along the way. Not trained as educators, but just interest in student learning. Yeah. So I'm going to stop here, and yep, invite some question. Yeah, a lot of things we learn along the way. Many people help us, and yep. So that's my half an hour, and hopefully informal way. And any question, anything I feedback on what we have done, and for our improvement. So yep, invite question and comment. Yeah. I'm looking at the YouTube, my Facebook. So as we learning Microsoft Team along the way.
For us, it's even tougher because we are supposed to be the trainers, and we ourselves found out about it on the 15th of March, and we had to conduct training on the 18th. So it was for. I know the biggest issue that was pointed out. They're saying that UKM Folio and Microsoft Teams seem to be two separate systems. Yes, they are two separate systems because one is developed by UKM, the other one came from Microsoft under the license from Kementerian Pengajian Tinggi. And for us, we ourselves only found out about it last minute. So as for Dato Ainul mentioned, his Mac cannot work with Microsoft Teams. The reason is very simple. Teams is a Microsoft product, and they did not have access to Apple's help in integrating Apple with Microsoft Teams. So my apologies to Dato Ainul, but we even met with Microsoft Malaysia that day, just to solve the issue. And they say they just cannot do it because without the cooperation of Apple themselves.
Oh. I'm using Mac along the way, and yeah, there's some small features as absent, and
Yes.
I have the full thing. Yeah.
Okay.
But so functional so far.
But whatever it is, I have to congratulate Prof. Tong for taking the trouble to mobilize everybody to help pitch in and make sure that everybody can cope. Congrats to you.
Yeah, thanks, and the team. Yes, I come with very little knowledge on online learning too, and yeah, so yeah, and any other? I don't read anything from Facebook. There's no question there. So I think some of them are still struggling with what to be spoon-fed. Yes, I think so. MHJ, I'm sorry I didn't read your name correctly. Yes, yes. But I think we can do our, just I'm learning and reading. We will do like a peers influence kind of thing. So as we mold the way how we teach, and they will feel left out if they don't follow the active way of learning. And one that discover it, they really enjoy active learning. Their participation, they can experience it. So that's what I've experienced along the way. I'm not sure the others. Do you have any experience with the student with want to be spoon-fed? The passive one, yeah. How do you deal with it? Sorry, I had to call you MHJ. I'm sorry. Do you want to share what you have experienced? MHJ? Oh, Hafizul. Mine not working. All right, no worry. So you can type if you want. We can read from there. Yes, yeah. Spoon feeding is a problem, but actually, I'm from a constructivist view. If you constructive view, meaning that whatever students doing is reflecting what we are doing. So if we change our way of teaching, they will change accordingly. Yeah, they will change accordingly. I think we have to embrace both technology as well as the pedagogy, so to speak. How students learn, how we design, and how do we change behavior, right? So I'm reading along as well with all this. Right, now it's 3:34. We promised an hour session, so now it's probably time. And yeah, if there's no question, we can put back the QR code for us to record the attendance. And thanks for coming on board. And yeah. Sham, yes, thank you, Zaki. Yeah. Thank you very much. I see. Yeah. I thought I see Prof. Shuib is with us today. Yeah. Right. Have a nice evening and happy breakfast later. Thank you. Bye.
Thank you, everyone.
Thanks, Ainul. Yep.
Learning about.
Thank you for all speakers for making the effort. Thank you very much.
Thank you, Azmi. Yep.
Thanks, Bob. Thanks.